before you even developed a biological sex in the womb, your body did something that was, frankly, incredibly risky.
Yeah, it really did.
I mean, it basically drilled this 3 to 5 centimeter hole straight through the dense, load-bearing muscles of your lower abdomen.
And it left behind a permanent anatomical tunnel.
Yeah.
For a massive portion of the population, that tunnel is essentially a ticking time bomb for structural failure.
Right, which is just wild to think about. We usually walk around assuming our abdominal wall is this, impenetrable shield holding our organs safely inside.
Exactly, but there is this built-in escape hatch, and it permanently compromises the integrity of the whole system.
Okay, let's unpack this. Our mission for this deep dive is to really map out this hidden passageway, the inguinal canal. We're going to look at the highly gendered biological cargo force through it.
And trace its bizarre origin story all the way back to the 8th week of fetal development.
Yeah, and finally, decode the mechanics of why this brilliant evolutionary workaround inevitably leads to one of the most feared structural failures in the human body, hernia.
To really understand the failure, you first have to understand the architecture.
Okay, so set the scene for us. Where exactly are we looking?
Geographically, we are looking right at the lower groin. The canal is this diagonal slit. It basically angles downwards and inwards toward the midline of your body.
Downwards and inwards, got it.
Right. It starts deep inside the abdominal wall at an opening called the deep inguinal ring, travels through the tissue, and exits closer to the surface.
At the superficial inguinal ring.
Exactly. Terminating near a notoriously weak anatomical zone known as Hesselbach's triangle.
Hesselbach's triangle. Okay, but if we're talking structural engineering here, the body didn't just leave an open pipe exposed to the elements, right?
No, definitely not. It constructed this tunnel using the surrounding tissue layers, and the sources reference a classic medical mnemonic to help catalog those building materials.
Oh, the maloti mnemonic, right?
Yeah, MALT. So muscles, aponeuroses, ligaments, and tendons.
Okay, so M is muscles, A is aponeuroses, which are like fibrous sheets, right?
Yes, broad sheets of tendon. And L is ligaments, T is tendon. But just listing materials doesn't really explain how the structure actually survives the sheer pressure of the human body.
Right, because there's a lot of pressure down there. How do these completely different materials, muscle, tendon, ligament, actually function together? Is it essentially like a secret passageway in a medieval castle?
Well, you have to picture it less like static castle walls and more like a dynamic pressurized valve.
A valve, okay.
Yeah, the roof of the canal is purely muscular, formed by the internal oblique and the transversus abdominis, and they have the ability to actively contract.
Oh, I see.
Then the front wall is an aponeurosis, that fiber sheet. The floor is constructed of rolled up ligaments, specifically the inguinal and lacunar ligaments.
Wow, a floor made of rolled up ligaments.
Right, and the back wall is this mix of tendon and a thin fascial layer called the transversalis fascia.
So it's basically a self-sealing mechanism. When you cough or like lift heavy weights at the gym, those muscular roof layers actively clamp down.
They do. They flatten the tunnel right against that dense ligament floor.
That is wild. It's like a blowout preventer on an oil rig, just designed to stop your organs from shooting out under high pressure.
What's fascinating here is the sheer architectural compensation the body employs, because the back wall of the canal is dangerously thin near that deep opening.
So a blowout right there should be basically inevitable.
It should be, but the body overlays the thickest, most robust part of the front aponeurotic wall directly over that flimsy back section.
Oh, wow. So the inherent weakness of the posterior wall is deliberately shielded by the maximum strength of the anterior wall.
Exactly. It's brilliant natural engineering.
But I mean, that blowout preventer can obviously still fail, and to understand the mechanics of that failure, we really have to look at the traffic actually flowing through the tunnel, right?
Right, and the traffic is entirely dictated by biological sex. The difference in sheer physical volume is staggering.
Staggering how? Like size-wise?
Size and contents, yeah. In a female body, the canal is quite narrow because it only houses a few small structures, primarily the round ligament of the uterus.
The round ligament. I read that this acts essentially as a biological mooring line. It attaches to the top of the uterus, runs all the way through the inguinal canal, and anchors solidly into the tissue of the labia majora.
That's it exactly. It just keeps the uterus safely tethered in a forward tilted position, providing necessary stability.
Okay, so to tether, are there nerves in there too?
Yes, you also find sensory nerves in the female canal, like the ilioinguinal nerve and the genital branch of the genitofemoral nerve.
And those just provide basic sensation to the labial area, right?
Correct. But in males, that specific genital branch nerve takes on an active mechanical role because the male inguinal canal is an entirely different beast.
Yeah, I mean, the male canal is packed. It has to house the massive spermatic cord, which connects the testes and the scrotum back to the abdominal cavity.
It is very crowded. The texts actually use another memory tool here, FANO times 3.
FANO times 3. Wait, so 3 of everything?
Basically, yeah.
Yeah.
There are 3 layers of fascia, 3 arteries, 3 nerves, and then the O stands for other vital structures jammed into this tiny space.
That is so much stuff. 3 fascial layers.
Yep, the internal spermatic, cremastric, and external spermatic fascia. And they aren't just protective sleeves, they allow the cord to physically glide.
Oh, I see. And what about that genital branch nerve you mentioned earlier?
Right, so in males, it powers the cremaster muscle embedded right within that fascia. It actively pulls the testes closer to the body for warmth, or relaxes to drop them away to cool down.
Here's where it gets really interesting, because we have 3 separate arteries, 3 distinct nerves, the ductus deferens for transporting sperm, and this highly specialized network of veins called the pampiniform plexus.
The pampiniform plexus, yes.
The sources call it a countercurrent heat exchange system. Isn't that wildly over-engineered? Packing an intricate HVAC system into a 3-centimeter tube.
It sounds like it, but the stakes for gonadal survival demand that level of engineering. Human spermatogenesis, the production of sperm, completely halts at normal core body temperature.
Wow, completely halts.
Completely. The testes must sit outside the body in the scrotum to remain a few degrees cooler. But the blood pumping down from the heart through the testicular artery is dangerously hot.
Right, it's at that core body temperature. So if that core temperature blood hits the testes directly, reproduction basically shuts down.
Exactly, and that is where the pampiniform plexus intercepts it. It is a dense intertwined mesh of veins carrying cooled blood back up from the testes.
Oh, so they physically wrap themselves around that hot incoming testicular artery.
Yes, they do. As they travel together in opposite directions within the tight confines of the canal, the heat actually transfers from the arterial blood to the venous blood.
Wow, so the arterial blood is chilled to the perfect ambient temperature just before it actually reaches the testes.
Exactly, it's a literal biological radiator.
That is incredible. But taking a step back here, why put the testes outside the body in the first place? Like, why force the anatomy to rely on this complex tunnel and radiator system?
To answer that, we really have to look all the way back to the 8th week of fetal development, because the reproductive organs do not start out in the pelvis.
Wait, really? Where do they start?
The gonads, whether they are destined to become ovaries or testes, initially form high up in the posterior abdominal wall. They're right next to the developing primitive kidneys.
The kidneys. Wow, sitting near the kidneys means they have to traverse the entire abdominal cavity just to reach the groin.
They do, and they follow a physical guide rope called the gubernaculum.
The gubernaculum, that's a great word.
It is. It's a bilateral ligament attached to the bottom of the gonad on one end and anchored to the developing scrotal or labial swellings below.
So as the fetus grows, the gubernaculum basically directs that downward migration.
Exactly. But getting to the bottom of the abdomen is one thing. Pushing through the dense muscular wall of the abdomen to get outside is another entirely.
Right. How does a tiny fetal structure bore a hole through thick muscle and tendon?
It utilizes a tool called the processus vaginalis. The peritoneum is the tough fibrous membrane lining the inside of the abdominal cavity.
Okay, the peritoneum.
Around week 12, a flask-shaped piece of this membrane bulges outward. It literally physically forces its way through the muscle layers of the anterior abdominal wall, excavating the inguinal canal.
Oh, and the testes just slide down right behind it.
Precisely, pulled by that gubernaculum.
So wait, As the testicles migrate from the back of the abdomen down into the scrotum, this processus vaginalis pouch pushes through the abdominal wall layers. Is it basically like dragging a heavy piece of furniture out of a room and accidentally taking the carpet with it?
That's exactly what it's like.
Creating a permanent physical pathway wrapped in the fibers of the room.
Yes, and if we connect this to the bigger picture, that carpet drag is the exact mechanism that creates the 3 distinct layers of fascia we talked about earlier in the spermatic cord.
Oh wow, so as the pouch and testes push through the inner, middle, and outer layers of the abdominal wall, they drag a sleeve of each layer down into the scrotum.
Exactly. The deep ring of the canal is where the drag started, and the superficial ring is where the tissue finally exited the muscle wall.
Man, that reframes the whole anatomy. It isn't just an empty hole, it's an extruded tube of abdominal muscle. When does this massive migration actually finish?
The final descent usually happens rapidly in the 3rd trimester, mostly between the 26th and 32nd weeks of gestation.
Okay.
It's a really critical developmental milestone. If the process stalls, which is a condition known as cryptorchidism, the testes remain trapped in the abdomen.
And that's bad because of the heat, right?
Very bad. Left inside that high temperature environment, the tissue will suffer irreversible damage, heavily impacting fertility and drastically increasing the risk of cancer.
Wow, so it requires immediate surgical correction.
It does, absolutely.
Okay, so the body successfully executes this high-stakes migration most of the time, but the bill basically comes due in adulthood, because that permanent carpet drag pathway means the abdominal wall can never fully seal.
Right, it is a permanent anatomical compromise. The canal is primed for structural failure, which manifests as the inguinal hernia.
Which is a super common issue, but we typically picture a hernia purely as a mechanical tear, right? Like something snapping because you deadlifted too much weight.
We do, but at a cellular level, the sources highlight that hernias are actually disorders of collagen.
Oh, really? Collagen being the primary structural protein making up our connective tissue.
Exactly. Many hernia patients possess an altered ratio of type 1 to type 3 collagen in their extracellular matrix. Their connective tissue is inherently stiffer, weaker, and less elastic than normal tissue.
So it just doesn't stretch or remodel properly under physical stress.
Right.
So you take a genetic baseline of brittle collagen, combine it with a pre-existing fetal tunnel, and the only thing missing is the trigger.
And the trigger is raised intra-abdominal pressure.
Like what kinds of things cause that?
A chronic cough from smoking, chronic straining, the physical displacement of pregnancy or heavy lifting, all of that spikes the pressure inside the abdominal cavity.
And physics dictates that pressure seeks the path of least resistance.
Exactly. So when that muscular blowout preventer we talked about earlier fails, abdominal contents, usually a loop of intestine or a pad of fat, are forced directly into the canal.
Yikes. The medical literature divides these failures into indirect and direct hernias. How do they mechanically differ?
Well, it comes down to the specific route the intestine takes. The anatomical dividing line is a set of blood vessels running vertically up the abdominal wall called the inferior epigastric vessels.
The inferior epigastric vessels.
An indirect hernia enters the canal lateral to those vessels at the deep inguinal ring. It takes the exact same long route the testicles took during the fetal carpet drag.
Oh, interesting. So it goes all the way down the tunnel.
Yes, and this almost always occurs because that fetal pouch, the processus vaginalis, failed to properly dissolve before birth, leaving the tunnel basically wide open.
So an indirect hernia relies on a congenital vulnerability. What about the direct hernia?
A direct hernia occurs medial to those epigastric vessels, directly inside Hasselbalch's triangle. It bypasses the deep ring completely.
Wait, so it doesn't even use the entrance of the tunnel?
Nope. The bowel simply punches straight through the weakened posterior wall of the canal and pops right out of the superficial ring.
Wow.
And this is acquired over time, resulting from the gradual degradation of those collagen tissues we mentioned.
Okay, so indirect takes the long way down the tunnel, while direct just kicks in the back door.
Exactly. And in rare instances, a patient suffers a catastrophic failure of both simultaneously.
Wait, both at the same time?
Yeah. A loop of bowel takes the long route through the deep ring, while a second loop punches through the back wall.
Oh my gosh.
Because the two herniated sacs straddle those inferior epigastric vessels, it forms a visual shape reminiscent of baggy trousers. Surgeons actually refer to it as a pantaloon hernia.
A pantaloon hernia, that is a very vivid image. So what does this all mean for you, the listener? I mean, if someone feels a physical mass in their groin, they know they have a structural failure. But what is the actual biological danger of a piece of intestine sitting inside that canal?
The danger relies entirely on blood supply. The clinical progression of a hernia goes from reducible to incarcerated to strangulated.
Okay, walk us through that. What is a reducible hernia?
A reducible hernia is manageable. The mass appears when you stand or lift, but when you lie supine, gravity and lower pressure allow the bowel to safely slip back into the abdominal cavity.
The pressure drops, so the bowel just retreats.
Right, but over time, the constant friction and displacement cause swelling and tissue scarring. The bowel gets trapped outside the abdominal cavity and just will not go back in.
And that is the incarcerated hernia.
Yes, it causes extreme pain and frequently leads to a severe bowel obstruction, essentially halting your entire digestive system.
Okay, and if the tissue swells even further and gets trapped even tighter,
Then it becomes a strangulated hernia. The narrow ring of the canal acts like a physical tourniquet.
oh no.
Yeah, it clamps down with such immense force that it crushes the arterial blood vessels feeding that trapped loop of intestine.
So the tissue is instantly starved of oxygen.
Exactly, and it begins to die. Ischemic necrosis sets in.
Dead intestinal tissue inside the body. I mean, that means the biological barrier breaks down. Bacteria from your gut would leak directly into your bloodstream.
Yes, leading to peritonitis, massive systemic infection, and rapid onset septic shock. A strangulated hernia is fatal if a surgeon does not intervene immediately to release the pressure and restore blood flow.
Wow, that escalates from a manageable lump to a fatal emergency terrifyingly fast. If a patient presents with a swollen groin, how does a doctor instantly differentiate a ticking time bomb like that from something benign, like a cyst?
The diagnostic physical exam actually exploits the mechanical physics we just discussed. The doctor will have the patient lie supine and ask them to cough.
Because coughing rapidly spikes that intra-abdominal pressure.
Exactly. If it's a hernia, the doctor will physically feel the mass expand and protrude as more bowel is forcefully pushed into the canal.
Okay, but there are other masses that form in that region, right? Like a hydrocele, which the text describes as just a localized buildup of clear fluid.
Right, so to differentiate a harmless fluid-filled hydrocele from a highly dangerous solid loop of herniated bowel, the doctor uses transillumination.
Transillumination, how does that work?
They literally shine a bright pen light directly through the tissue of the scrotum. If the light passes completely through and the mass glows like a red lantern, the light is hitting clear fluid.
Oh, I see. But if the light hits a wall of dark tissue,
Then the light is blocked by the solid, dense mass of an intestine that has traveled all the way down the canal. The diagnosis of a hernia is instantly confirmed.
that is a brilliant diagnostic tool. We started today looking at a 3-centimeter tunnel, and honestly uncovered an absolute masterclass in biological engineering and inevitable compromise.
Yeah, we saw how the dynamic valve of those multiple layers attempts to protect us.
Right, and how the pampiniform plexus functions as that intricate heat exchange system, and how that brilliant fetal carpet drag leaves a permanent scar that can unravel into a strangulated hernia.
It really highlights how evolutionary pressures, specifically the absolute necessity to keep gonads at precise temperatures for reproduction force the human body to accept massive structural vulnerabilities in the abdominal wall.
I want to leave you with a final concept that fundamentally shifts how you should view your own anatomy. The inguinal canal exists in every single human being. Male or female, you have this hidden tunnel. And why? Because the blueprint for it was laid down before your embryonic body ever differentiated its sex.
That's right. Your body carved out that escape hatch in preparation for a massive biological journey before it even knew if that journey was required. That fetal blueprint, executed before your sex was determined, permanently dictates the physical vulnerabilities you walk around with today.
We like to think of our bodies as these solid, finished, perfected designs. But in reality, we are carrying around the physical remnants of our own construction. We aren't impermeable. We are a beautifully complex, highly vulnerable history of exactly how we were built.